Thank you very much, Nico. It's a pleasure to be here, and of course, it's always a pleasure to work with our students in Coburg and our members of the staff and faculty there. Unfortunately, this summer we won't have the opportunity to have our exchange students physically with us in Georgetown. That's always a pleasure to deal with them. And hopefully this whole crisis will blow over again. I'll be able to see you and all my friends and students back in Coburg next December. A bit of clarification, I do not have direct contact with the president.
I said almost.
No, no, no. There's quite a number of steps between me and the president, but I am serving on the Department of Defense COVID Response Task Force. That's part of our effort with the Defense Medical Ethics Commission, and I'm very proud to work with those folks. And we're also doing a lot of work, of course, at Georgetown, trying to maintain some stability and also develop medical and bioethical principles, guidelines, and policies that are viable for COVID response and certainly COVID protection. Thankfully, no one who I know firsthand or personally has come down with this disease, at least not to the extent that it's been so severe. As we'll hear a little bit later in my presentation, there is the possibility that this was going around a bit earlier. And as a consequence, some people may have been earlier infected. That's still very, very hypothetical. But with antibody testing, particularly of individuals who do not appear to present with any signs or symptoms, or those who seem to have mild flu-like symptoms back in January or early February, it may have been possible that this was an early, what we call viral load of the COVID-19 virus. But that remains to be determined. But at this point, no one who I know personally has been infected with this in a way that is severe enough to warrant hospitalization or any form of critical care. So that's the good news. The continued distressing news is that here in the Washington area, we're anticipating a peak somewhere between the end of April and middle of June. This is very typical with other peaks here in the United States. The European peak may, in fact, have sort of reached its apex now, we believe, although there's still some thought that there may be a secondary milder peak that occurs a little later in the spring. And as we talk later in today's presentation, we'll see that there is, in fact, what appears to be a seasonal pattern of the virus infection and its proliferation in populations, although that does not appear to be weather dependent. That has a lot more to do with some of the factors that we instill.
Okay.
So that said, let me just give also a disclaimer. Please, everything that I'm about to say in this presentation, both live and of course in its recording, is my particular perspectives based upon the information that I have to date, and that is today, Thursday, April 9th, 2020. This is a rapidly changing situation. We're learning more about this virus literally every day. We're learning more about what the virus responds to, its epidemiological pattern, its pathological features, patterns of infection, patterns of response, and we're also developing a whole host of potential interventions that can be used to prevent the virus in some cases, to lessen its signs and symptoms in others, and to treat it and eradicate in yet others. This is an evolving situation. Please understand that what I'm presenting to you today represents the news and the latest findings as I know them, as they're made available to me in my professional roles, and I'm trying to make them available to you. This whole situation could change tomorrow. And hopefully it will change tomorrow for the better. The situation right now, once again, appears that this definitely is spreading towards a pandemic peak somewhere around late spring. Many countries have experienced what they believe to be their peak in infectiousness, and now their peaks seem to be leveling off or in some cases decreasing. That's hopeful news. Again, as a disclaimer, nothing that I'm telling you here represents the official word from any of the organizations that I'm involved with. This is not the perspective or position necessarily of the United States Department of Defense, Health and Human Services Administration, or even Georgetown University. This is me coming to you, telling you the information that I know, either by my firsthand interactions and experiences professionally through with my colleagues and or my ongoing research into this particular area. So I just wanted to make sure that this information remains exactly what it is. My perspective based on the facts available to me at this time. Okay?
Thank you very much for clarifying, Jim. Let me just ask the students, can you hear and listen Professor Giordano in a good manner, or should he slow down? Is everything okay? So just give me a thumbs up. You're speaking, okay? Thumbs up, thumbs up. Okay.
Naja, liebe Studenten, normalerweise, wenn ich spreche Deutsch und ja, ich kann ja ziemlich gut Deutsch sprechen, aber für diesen Vortrag, wir sollen diesen Vortrag, das sind ganz auf Englisch halten und
Ja,
ja, können wir etwas Fragen zum bis Ende nehmen und dann können wir eine Frage- und Antworten-Session haben, entweder auf Englisch oder auf Deutsch. Und ja, normalerweise, wenn spreche ich Englisch, ich spreche sehr, sehr langsam. Und an diesem Weg kann ich sehr, sehr gut zu Verständnis und dann vielleicht können wir auch ein sehr gutes Verständnis des ganzen Material, das ganze PowerPoint-Präsentation. Okay, so wenn alles klar ist, dann kann ich weitergehen.
jawohl.
Ja, gut dann. So this is the COVID virus. It is a member of the Coronaviridae family. It is called a coronavirus because, as you can see from the illustration, it has a corona or a ring or a crown of what looks like little spikes that project out from the viral body itself. The actual viral material is housed inside of that sphere. The outer material is primarily protein. These little spikes that stick off are referred to as glycoprotein spikes. The end of those spikes are very important because those are the binding regions that need to be cleaved or interact with some form of cellular protein. One thing I think becomes very important to understand is that a virus is not alive. It is not a living organism. It's not like a bacterium or a fungus. It is nothing more than pure biological informational material. It is genetic material. And as biological informational material, the function of the virus is to program itself so as to replicate. So, if you will, and I'm being very anthropomorphic here, the intent of the virus, what this biological material intends to do, in other words, its primary function is to replicate. To replicate, it requires a host. It cannot do this on its own. It does not have any of the necessary cellular machinery and mechanisms that are required for genetic replication. So it hijacks, if you will, cells that have a high host affinity for the virus, and it uses those cells, mechanisms, and machinery for its own replication. In other words, it takes a host cell by infecting the host cell with its own genetic material, it transforms the host cell into a virus factory. This particular virus is called SARS coronavirus type 2. Since it was first identified in 2019, its more common name is coronavirus identification 19 or COVID 19. It is a recombinant RNA virus. In other words, the virus itself is composed of ribonucleic acids, not just deoxyribonucleic acids. And having ribonucleic acids is then able to transform itself fairly rapidly into viral proteins. And these viral proteins then become the full virus, which then matures and then infects other cells. The important part of this, and one of the important parts in stopping the virus, is to understand how the virus attaches to other cells. And this is where those spikes in this particular illustration, colored red for easy identification, are so important. It appears that as the virus changes its form in an animal species, it develops an increased affinity, in other words, an increased ability to bind with various types of animal proteins. In its original animal host, which was a horseshoe bat, as we will see momentarily, these proteins were highly specific for interacting with the cells of the respiratory tract of the horseshoe bat. However, what can happen is the virus will mutate, the virus will adapt, it will recombine its RNA so as to make it more replicable, repeatable. And the way it will do this is by jumping from one species to another, particularly if a new species tends to be what we call an opportune host. In other words, if the virus is doing well and reproducing in one species, and that species comes in contact with another species, the new species may not have any immunity to the virus, and so the virus, by contacting the new species, finds an opportune and very rich and viable environment for its own replication. What we know is that this particular virus, the coronavirus type 2, COVID 19, had a jump from an initial animal species to a probable intermediate species to humans. There is some thought that this type of coronavirus, a virus that is similar to the one we have now, has actually been in human species for a while. This is the same type of virus, although not identical to the COVID-19, that caused previous viral epidemics such as SARS and MERS. And we understand that coronaviruses, in general, are not uncommon in human populations. There is a hypothesis, just a hypothesis, that this coronavirus, COVID-19, had actually been in human populations for some time, perhaps many months, perhaps many years, but that its susceptibility of the human host was maintained at a low level because of human immunology to prior forms of the virus. In other words, it may very well be that the virus already had, quote, experience in a human host, but by subtle changes of the viral material, its genetic material and the viral structure, it became more virulent, more potent, and more infectious in humans. This is a hypothesis. We really will not understand this completely until we do more global serological testing. In other words, testing antibodies of individuals who did not get infected with this virus during this period, but may present with antibodies because they have been exposed to it previously. So the thought is that this may have either been a pure animal virus that then spilled over into humans because of human-animal contact, or it may have been an animal virus that engaged mutations both in the animal species and perhaps in the human species to create a, quote, perfect storm. The origins of this virus, as we can best determine, were in a species of bat called the horseshoe bat, which is illustrated for you in this slide. The horseshoe bat is so named because if we look at the bat's face on the upper right, it has a horseshoe-like arrangement of its mouth and nose parts. And the horseshoe bat, like so many bats, has an immune system that is virally tolerant. In other words, it can tolerate the virus without getting sick. As a result, it tends to harbor the virus. It is a virus-making factory. And the coronavirus seems to be very active in colonies of horseshoe bats. It also appears that some of the horseshoe bats may have developed a reactive immunity to the coronavirus, and as a result, there may be particularly infected populations of horseshoe bats, and these horseshoe bats may not be as well as their other infected cohorts. In other words, it may be that a particular strain of this virus made particular horseshoe bats somewhat sicker, literally sicker, and in their illness behavior had more contact with humans. There's also the idea that human intrusion into the ecologies and environments of horseshoe bats, particularly those horseshoe bats with a variable environment because they were infected with this virus at a high level, may have led to an increased human-bat contact, and as a consequence of the human-bat contact, the virus had greater exposure to humans, became more modified to engage a human host, and therefore the infectiousness in humans increased. Again, this is hypothetical based upon some of the knowledge that is evolving about the presentation, epidemiology, and demography of coronavirus infection. It is also very likely that the coronavirus utilized an intermediate species, and it is probable that the intermediate species is this animal called a pangolin. A pangolin, as you can see, is this cute scaled animal, which is very similar to an anteater. And pangolins are the most exported animal in the world. Pangolins are exported worldwide for a variety of uses. In some cases, their meats are seen as edible. In other instances, their scales are viewed as having potential for various forms of folk medicine and having potential nutritive or curing powers. And it is a very curious animal, and as a result is transported not only for its meat and potential, what we call zooceutical capabilities of its scales, but also to simply use as an observed animal. Interestingly, it seems that the pangolin may have become an intermediate vector for the coronavirus. In other words, the bat virus spread to the pangolin, and then the use of products of the pangolin, whether it is the pangolin meat or the pangolin scales, or simply contact with pangolins, provided an additional vector and increased opportunity for the virus to develop activity in a human host. This process of a disease that is ordinarily an animal disease, then becoming a human disease, is referred to as zoonotic transfer, or a zoonotic disease. This particular instance is one of spillover, where the virus appeared to have a very high infection, reproducibility rate, and epidemiological rate of prevalence in bats, used an intermediate species as the pangolin, and it appears that contact with the bat and or the pangolins, either through their scales, physical contact with the animal, or the use of their meat, then provided the nexus to the human population. It also appears that the use of the pangolin scales in various preparations of folk cures and various foodstuffs may have allowed the active virus to directly transfer from the pangolin to humans and modify further so as to become more opportunistic and more viable in the human host. Nevertheless, we see human infection. There is some question as to when patient zero, or the first actual patient presenting with the full COVID-19 syndrome, became sick. The evidence that we have at this particular point suggests that the first patient, or patient zero, actually presented with signs and symptoms as early as perhaps early to mid-autumn 2019. That's considerably earlier than the internationally known first reported cases announced by China, which was in late November or early December. That does not necessarily mean that there was an intentional cover-up of cases, but rather that it was only recognized that this patient was presenting with this type of coronavirus after the fact. Clearly, when there's only an N of one, a single case, and that case is remarkable enough to be noticed as something distinct, different, or variable, then attention to that case is paid, and it may very well be that epidemiological attention to that case is paid as an identified case of something new. That seems to be the situation here. So, irrespective of whether or not the true patient zero was infected and presented with the COVID-19 syndrome, or what we refer to as a constellation of signs and symptoms, as early as autumn 2019, what we do know is that the disease reached epidemic proportions, certainly within Wuhan, China, and the province of Hubei around Wuhan, and then spread internationally via international travel. This international spread began in and around December of 2019, with dispersion throughout winter of 2019, ultimately hitting global epidemic to pandemic characteristics by February to March 2020. What is very important and what I wish to dispel is what is on the bottom of this slide. There is no evidence that I have seen to indicate or suggest that this is an identified, intentionally developed, or released biological weapon. Let me say that one more time. And the reason I say that one more time is that, as many of you may know, one of my areas of professional activity is in biological, chemical, and novel weapons. Once again, there is nothing that I have seen, nothing that I have read, no evidence that has been presented to me that indicates or suggests that there have been synthetic, man-made modifications to this virus that would be representative of a man-made biological weapon. As well, there is no evidence that suggests or indicates that this is a biological weapon that was then developed or let loose by intent. All indications, all information that I have been able to read and have access to, all of the information my colleagues have access to, indicate that this is a naturally occurring variant virus that had a zoonotic spillover effect that then found an opportunistic host in humans and became rapidly reproductive and rapidly infectious. Once again, there is no evidence to indicate or suggest that this has been identified as an intentionally developed or released biological weapon. And that is very important because one of the potential postures that we're seeing internationally is one of what we would consider to be epidemiological xenophobia. In other words, people are upset, people are afraid, people are wary of foreigners because they feel that this may be either a foreign agent or may have some intent as a biological weapon. Please let me dispel those falsehoods. What is so important at this time and going forward is an understanding of the need for multinational, international, global cooperation to identify those risks and threats to our public health and to our public and personal safety, and to work together in a collaborative way to identify, prepare for, intervene, and in some cases, prevent these risks from becoming threats and harms. That said, we are in the midst of a pandemic. And being in the midst of a pandemic, it becomes important to understand what this thing is and what it does. For the next few minutes, I'd like to discuss with you the pathological features of the SARS coronavirus type 2 of COVID-19 and discuss how this then creates the clinical signs and symptoms that are so evident, the progression of these signs and symptoms, and what's being done to treat them, and in some cases, to prevent them in the future. Again, the coronavirus is a respiratory virus. Initially, it may contact with the upper respiratory tract via the nasal mucosa, the oral mucosa, and/or the mucosa of the eyes. Once it enters the upper respiratory tract, initial infection of the upper respiratory tract can rapidly lead to secondary infection of the middle and lower respiratory tract, the throat, the bronchial tubes, and ultimately the lungs, the deeper lungs. When the virus replicates within the lungs, it then causes a disruption of the superficial cells that line the air sacs of the lungs called the alveoli, and the long tubes that lead to the alveoli, which are called the bronchioli and the bronchioles and the bronchi. So what you see is ultimately the disease progresses from the upper respiratory tract to the middle respiratory tract to the lower respiratory tract. The lower respiratory tract provides an ideal environment for the virus replication. And what we see is that by infecting the epithelial cells of the deep lungs, the virus disrupts the structure and function of those cells. Those cells essentially become virus-producing cells rather than functional respiratory epithelial cells. Now, what's important to know is that those cells of the respiratory tract, both of the upper respiratory tract and middle and parts of the lower respiratory tract, contain fine filaments on their surface called cilia. They look like this. And these cilia perform a useful function in that they keep foreign objects, bacteria, and other forms of debris out of the deeper respiratory tract and maintained in the upper and middle respiratory tract, where they can then be either expelled by coughing or can be acted upon by the body's immune system without damaging the lower and very vulnerable cells of the lower respiratory tract deep in the lungs. However, when the coronavirus infects these respiratory epithelial cells, it destroys not only the function of the cells, turning these cells into virus factories, but also the structure of the cells. Those little fibers, those cilia on top of the cells that are so useful in keeping debris and bacteria out of the lungs, no longer are functional. They become structurally impaired and functionally useless. So as a consequence, what we see is that the cells of the lungs are structurally different, functionally different, and this leaves the lung vulnerable to two things. First, the fact that these lung cells are now producing viruses engages an immune system that seeks to reduce the amount of virus in the body by attacking the cells that are producing it. Please understand, your body is now attacking its own lung cells. Those lung cells have been turned into virus machines, so the idea is that the immune system will target those cells, destroy those cells, and in that way decrease viral production. However, there is also the possibility that the immune destruction of those cells has what is referred to in military terms as collateral damage. In other words, the immune system fails to recognize those cells that are infected with virus from those cells that are not infected with virus, and you begin to develop an immune response against lung cells more generally. This can then lead to inflammation within the lungs, which can then produce a viral pneumonia. As well, what can happen is the destruction of those respiratory cells by the virus itself can leave those cells and the lungs vulnerable to secondary bacterial infection. At almost all times of every day, we are exposed to a range of bacteria in our environment. And our bodies do a very good job in suppressing bacterial overgrowth and preventing bacterial infection. But when the immune system is preoccupied fighting a virus, when the virus and the immune system are destroying and or disrupting, respectively, the structure and function of respiratory cells that are useful in maintaining response against and defense against bacteria, then the possibility for secondary bacterial overgrowth and bacterial reinfection becomes relatively high. Taken together, the decrease in the effectiveness of the respiratory cells against bacteria and the decreased capability of the respiratory cells to do their function and the disruption of the structure of the epithelial cells and the epithelial system itself within the pulmonary system of the lungs lead to a decreased capability to breathe. In other words, a decreased respiratory capacity. With a decreased respiratory capacity, we're seeing a decrease in the capability of the body to extract oxygen from the lungs into the bloodstream and then distribute that oxygenated blood throughout the body. Characteristically, what this means is that the individual will have a lower oxygen saturation, will become hypoxic. In other words, their total body available oxygen is lower, and the body's functions that are necessary and reliant upon oxygen will decrease. The workload of the heart will increase, the workload of the lungs will increase, but since the lungs are already compromised by the virus and the immune response, what is happening is the workload is increasing on the lungs and on the heart, and the capability of those systems to function decreases. With increasing immunological response against the lung tissue and with increasing effectiveness of the virus to then proliferate throughout the lungs, the pneumonia can rapidly develop into something called acute respiratory distress syndrome, or ARDS. Acute respiratory distress syndrome occurs when the body releases a host, a literal flood of inflammatory mediating chemicals. The immune system, now no longer capable to simply suppress the viral overgrowth, throws everything it has at it. Now what happens is the immune system essentially pulls out all the stops, if you will, hits the little red button, so to speak, and now declares thermonuclear war on the virus. But what's happening is there's the release of the body's weapons that are necessary for the immune response and the inflammatory response, and these chemicals are referred to as cytokines. the entire body reacts so as to create an environment that is not habitable for the virus and to then decrease the infection. But the effect goes overboard. Now, what happens is you get a virtual storm of the release of those chemicals that the body uses to produce inflammation, and through inflammation, engage the immune response and suppress infection. Now you are in an over-inflammatory state, a hyper-inflammatory state. And in the hyper-inflammatory state, what we see is changes in blood pressure, a rise in temperature, increased stress upon the heart, changes in kidney function, changes in liver function. The changes in kidney and liver function as a result of changes in cardiac function then lead to a rise in toxins that are not being excreted effectively from the body. The individual is not extracting oxygen from the lungs and is building up toxic metabolites from their own metabolic physiological effects. And so what we then see is that many organ systems will begin to fail. The workload on the heart is increased, the function of the kidneys is decreased, the function of the liver is decreased, the oxygen base balance within the bodily systems changes. This then produces problems for cerebral circulation and brain function, and the individual can indeed get into sequential organ system failure, ultimately leading to crises of function, coma, and death. That's the most severe case presentation. But what we know is that the symptoms and signs of COVID-19 progress differentially. And there may be two, what we call constellation types of symptoms. The most common symptoms that one will encounter are shown on the left-hand side of this slide. They include malaise. In other words, you just don't feel good. Characteristically, that is coupled by profound fatigue. It's not just that you're sleepy, you are profoundly tired. You feel as if your body were made of lead and that you're dragging around 200 kilos worth of weight behind you every time you move. Early symptoms also may include a loss of the ability to smell or taste. The reason for that is that the virus has infected the cells of the upper respiratory tract, and those cells that are responsible for maintaining the mucus balance of the respiratory tract that are important to dissolve chemicals that then allow us to smell seem to be dysfunctional. And since much of taste is reliant upon smell, many patients report a loss of both smell and taste. Things don't smell the way they did. Things don't taste the way they did, or they don't taste like anything at all. Many patients also report early on a headache, a global headache. Their whole head seems to hurt. The characteristic sign that is indicative of a viral infection is usually fever, and COVID-19 is no different. COVID-19 presents with a sustained fever of greater than 39 to 41 degrees, with the fever peaking in the evenings and at nighttime. The fever characteristically goes up at night. Please be aware that our normal body temperature varies throughout the course of the day. And for many people, their body temperature is somewhat lower, somewhere between 36 and 38 degrees. However, this is not just the normal variation in our regular body temperature. This represents what is abnormal for you. Not only is your temperature elevated, but you feel feverish, chills, sweats, feelings of heaviness, malaise, body aches. As well, another sentinel symptom or sign is a dry and non-productive cough. This is not just clearing your throat. It is a cough that comes from deep in the chest, where you feel it in your chest, and it may be painful or at least uncomfortable, particularly right in the middle of your chest. If in fact the cough persists, many patients complain of shortness of breath, as if they cannot breathe deeply enough to fully fill their lungs. Those are the common constellation of signs and symptoms. There also appears to be a variant presentation that is, although less common, certainly viable and indicative of COVID-19 infection. Once again, upper respiratory signs are present, but these seem to predominate. This is as if the entirety of the viral progression does not move into the lower respiratory tract, but remains here. Here we're seeing upper respiratory signs and symptoms: stuffy nose, runny nose, watery eyes, sore throat, conjunctivitis, which is itchy eyes, irritated eyes, and a viral infection called pink eye. We call it pink eye because the linings of the eyes, the part underneath, become very, very red and inflamed. We also have headache in this variant symptoms, but this symptom variation is more indicative of those individuals who present with, again, the variable form of upper respiratory infection, and they may also develop some secondary abdominal discomfort, nausea with or without vomiting, and in some cases, diarrhea. It's not well known why these individuals present with the abdominal features. One thought is that the virus itself, in one of its variant forms, may be able to disrupt the environment of the GI tract. But more than likely, what's happening is a lower level of cytokine release that then disrupts the stability of the GI tract, which then leads to problems with fluid balance in the GI tract, abdominal discomfort, and of course, nausea, in some cases, vomiting and diarrhea. Irrespective of whether it is the first or the second variant, in other words, the more common signs and symptoms or the less common signs and symptoms, what is the expected time course of this disease? After initial exposure, most individuals will develop signs and symptoms within 2 to 11 days. The average is about 5 days after exposure. And these are the initial symptoms. So you're exposed, let's say on day 1, and somewhere between day 1 and day 15 after exposure, characteristically, those signs and symptoms will become prevalent, noticeable, and very often bothersome. Those initial symptoms once again include malaise, headache, perhaps a sore throat, and fever. Those symptoms tend to progress for 5 days once they have appeared. The 5 to 6 day period of symptomatic presentation appears to be a critical time, because at this time, the disease can take one of 2 potential, we call pathologic pathways or trajectories. One is that the symptoms will begin to get better. You will see a lessening in the presentation of symptoms and or their severity. In other words, the immune system is working well, is not overreacting or underreacting, and is fighting off the virus and its effects effectively. However, in some people, their immune system is not working well, or their immune system is working too well, and in and around the 5 day point, their symptoms will not begin to dissipate or lessen, but will actually begin to get worse. Now we're seeing individuals whose cough gets worse, whose fever gets worse, whose shortness of breath gets worse, whose headache gets worse. So what we're seeing is at the 5 day point of symptoms, you'll either start to get better or you will start to get worse. A critical point is at the 10 day point of symptoms. So now we've had symptoms for 5 days, and the symptoms have not gotten any better, so we have an additional 5 days. If the symptoms have not gotten better by 10 days following infection, it is very likely that this patient is not going to recover on their own, but will require significant medical support to get them through their recovery. Very often, this is the point where patients will develop active and evident pneumonia. Now, let me stop here for just a moment. Interestingly, what we are finding is that many patients actually develop pneumonia early on, somewhere after 4 or 5 days of initial symptoms. But the extent of the pneumonia, although perhaps bilateral in both lungs, does not seem to warrant initial clinical intention. In other words, these people don't realize they have pneumonia. They're not having problems breathing. they're not having shortness of breath, and they're not presenting with the classical pneumonia signs and symptoms. However, in this latter case, after 10 days, certainly the pneumonia has worsened to a point where individuals are having a very hard time breathing, a very high fever, and their overall feeling is very bad. The malaise is very strong, they're exceedingly tired, their fever is very high, they're not able to breathe. This is a critical time because this is the period where patients will require frank hospitalization. And many of the patients who then reach this point may progress to severe and/or critical stages of the disease, also presenting with cytokine storm and acute respiratory distress syndrome. What is the epidemiological demography of distribution of signs and symptoms in patients? The good news is that perhaps greater than 80% of individuals who are infected will present with only mild to moderate symptoms. Now, that's not to lessen the experience of being infected with coronavirus. Even mild symptoms of the coronavirus can present as a rather severe flu, headache, body aches, fever. Not pleasant. Moderate symptoms include heavy cough, shortness of breath, continuous fever throughout the day. 14% of patients will present with moderate to severe signs and symptoms that will characteristically require hospitalization, usually for supplemental oxygen and/or treatment of fever in an observed environment. About 5% of patients, particularly those that are vulnerable, the aged, those with immunological disorders, diabetes, pulmonary disease, renal disease, cardiac disease, pre-existing neurodegenerative diseases, other forms of autoimmunological diseases and immunological suppression due to both transplant or HIV. Certainly, these individuals are at a higher risk of progressing to severe forms and critical forms of the illness. But again, one of the things that is coming to light is that other individuals who seem to be perfectly healthy, younger, without any additional morbidities, illnesses, or injuries, can also progress rapidly to this critical stage if their body underreacts or overreacts to the virus. These are individuals who will then require mechanical ventilatory support to be able to breathe, and characteristically will require multiple medications to maintain their blood pressure, suppress their fever, and maintain their overall physiological and metabolic health. What's important to note as well is that some patients appear to experience very mild symptoms or no symptoms at all. In some individuals, infection, although can be profound, in other words, they will have a high virus load, will not develop the constellation of signs and symptoms indicative of the COVID syndrome. These are individuals who appear to be carriers of the disease, but do not express any of the overt signs or subjective symptoms of illness. But what is important to note is that all infected patients may be able to, and perhaps can, transmit the disease anywhere between 2 and 25 days after infection. And we're still not really sure as to those individuals who do not present with signs and symptoms, if in fact they will be able to spread the disease, even if they have developed antibodies. So again, here, a critical issue is understanding how the disease presents, how people get infected, what their response to the infection is, and what their response means for their vulnerability to reinfection or relative immunity and resistance to subsequent infection. That said, there are a lot of myths out there about the coronavirus. And I think at this point, having given you a lot of factual information, it becomes important to dispel some of the more common COVID-19 myths. First, as I mentioned before, COVID-19 is not a biological weapon. It was not developed or released by any nation state or rogue actor to create this pandemic. Second, it is not a variant of human immunodeficiency virus. It is not a variant form of AIDS. Third, there is no current vaccine available. the vaccine is not available and is being sequestered or being withheld from the population so as to drive up or alter the economics. Children are not naturally immune. Curiously, it does seem that children are less susceptible to the effects of the virus, and there are a number of hypotheses as why this might be the case, not least of which is that children's immune systems are not fully developed, and as a consequence, their overreaction to viruses may not be as severe as in adults. And it may also be that children being exposed to a range of various pathogens in their school and play environments have a more rebounding or more adequately responsive immune system. Both of those ideas are purely hypothetical. That doesn't mean that children cannot become infected and cannot become sick. They can, and they do. But it seems as if the epidemiological demography of COVID-19 is lesser in children than it is in adults. Also, the myth that if you can hold your breath for 10 seconds without coughing, you do not have the virus must be dispelled. Many people cannot hold their breath for 10 seconds, and many people can hold their breath for 10 seconds even if they have the virus. There are also a number of misinformations out there about what this virus can or should be treated with. High doses of vitamin C are not effective in preventing or treating the virus. High doses of garlic or drinking garlic water do absolutely nothing to affect this virus. Overhydration, drinking gallons of water a day, are not going to flush the virus from your system and prevent you from getting sick. That doesn't mean you shouldn't stay well hydrated, but that is not a direct treatment or prevention for COVID-19. Nor is taking alcohol baths or alcohol showers to totally disinfect your body. Yes, it is important to wash your hands with soap and water or an alcohol-based disinfectant that is greater than 70% alcohol, but bathing in alcohol, gargling with alcohol, taking alcohol showers, total myth. What are some facts that are important and factors that are important for intervening against the COVID-19 virus? Clearly, it is important to flatten the curve. In other words, to decrease the capability for infection, reproduction, and spread. One of the most important factors in flattening the curve is, as you know, physical distancing. And I stress physical distance because physical distance does not mean you have to be antisocial. Maintain contact with your friends and family, utilizing the internet resources that you have, utilizing your phone, writing letters, Facebook, Skype. These are all wonderful means and media to maintain the social contact we crave and we need as humans, but maintaining the physical distancing that is so important for flattening the curve of the COVID-19 virus. When we're talking about physical distancing, we're talking about 1.5 meters spread, at least, between you and another person. We're talking about a 10 to 15 second delay in what we call serial space occupation. Let me explain. If here's one person and here is the other person, and they are 1.5 meters apart, but then this person moves on and this person moves into their space, now you have space occupation. Give people about a 10 to 15 second window of movement before you then move into their space. This might not always be possible, but of course, this is one of the reasons why we are limiting those social or public gatherings, because the capability to interact with people's previously occupied spaces may lead to an increased susceptibility for the aerosolized droplets of the virus to infect others. Certainly, you, as well as we are in the United States, are under dictate for no social gatherings, particularly with people who are unknown. In other words, no bars, no clubs, no restaurants, and no parties, gatherings, meetings, etc. The idea here is physical distancing as much as possible so as to decrease or at least severely limit the potential interpersonal spread. Hand washing is critical. 20 seconds is essential with soap and with water. Thorough hand washing is putting the soap on the hands under running water, scrubbing vigorously, making sure to scrub in between the fingers, the back hands, side of the hands, up to the wrists, washing underwater while rubbing the hands, and then being sure to not touch the faucet, but rather use a rag if you must turn it, a towel, or use your elbow if you have a lift type of faucet. Masks in public. Now, the World Health Organization and the Centers for Disease Control here in the United States are strongly advocating that if you must go to public spaces, shopping, out in public where there's other people, to wear a mask, or to develop your own mask utilizing a bandana, a kerchief, or multiple layers of cotton. The reason there is it provides a primary barrier for aerosolized droplets should you come in contact with that. When utilizing the mask, what's important is that the mask cover your nose and mouth, thus, and that when you remove the mask, you keep your gloves on, remove the mask, fold the mask with your gloves on, wash the mask if it is a washable mask, or dispose of the mask, and then take your gloves off. As well, object contact safety is also important. Put gloves on when you go to the store, when you touch objects, or when you bring objects home or have food delivered. Empty the contents of one thing into another receptacle or to another container, and then throw the original contents away, the original containers away. Disinfect plastics and metal with 70% alcohol solution or a commercial disinfecting spray. And after you have done that, then remove your gloves. And the way we remove gloves is as follows. Remove the one glove. This hand is still gloved. Reach beneath the glove, pull the glove off, and then discard. In other words, do not let your bare flesh touch the surface of the outside of the gloves. That's what's called sterile procedure or semi-sterile procedure. And then, of course, after you've taken your gloves off, after you've transferred your takeout food, your shopping, your groceries to secondary containers, once again, wash your hands. But one of the keys for successful intervention is, in fact, testing. There are a number of different types of tests, and one of the benefits that you're having in Germany is a much more effective testing set of protocols and availability than we have here in the United States at present. We can test directly for the coronavirus utilizing something called PCR, or chromatographic analysis, where a swab is put into the nasopharyngeal area, goes up the nose, and they test directly for the presence of the virus. It's also very important to test people's blood for the presence of antibodies against COVID-19. My research group, coupled with others, feel that advanced and widely available serological testing will be very important to be able to determine who has an active infection, who was infected, who has not yet been infected, and who therefore may be vulnerable. And ultimately, it will become important as we move forward to institute some of the surveillance procedures that have been, in fact, put into place in certain other countries. We need not necessarily look at China, because we may appreciate that China is a somewhat more closed society, and some of their authoritarian political positions may not be tenable, viable, or entertainable in countries like Germany or the United States. But certainly Germany is doing a very good job with testing and with control, certainly using physical distancing and social contact controls. And we've also seen that countries like South Korea, Singapore, have also done very well because they've been able to monitor their population utilizing social media. So what we find is the development of what some people are referring to as a protective panopticon. In other words, during this period of time and as we move forward, it may become important to monitor people's presence of whether they are infected or not, whether they've recovered or not, whether they are vulnerable or not, where they're moving, who they're interacting with, and what variable spaces are being occupied by people who are recovered or people who are well or people who are infected. But of course, this then raises concerns about not only prevention and public health, but personal privacy. Irrespective of our surveillance and testing, what will become important is how we treat or prevent this disorder. At this point, treatment for those mild cases is primarily relegated to symptom alleviation. Paracetamol for fever, hydration for making sure individuals keep their fever down and don't lose too much of their bodily fluids through sweating. In some cases, we're now looking at the use of antivirals. The one that is getting the most attention is one being manufactured by the Gilead Science Corporation called remdesivir. It is still an experimental drug. It is what's called an investigational drug, but there are experimental trials that are currently underway in the United States and elsewhere. Another drug that has been widely used or is considered for wide use might be ivermectin. And ivermectin is widely used, for example, in veterinary preparations to prevent against fungal overgrowth in horses and livestock. And it seems that ivermectin may be able to disrupt the processes by which the virus reproduces. It too is being considered for human use. Another consideration that has been growing with interest and perhaps consideration for use in practice is the potential for low-dose radiation, X-radiation, for those very critical patients who progressed into cytokine storm and acute respiratory distress syndrome. This is based upon an existing literature to suggest that low-dose radiation, perhaps even single dosing, may be useful in decreasing or suppressing the body's over-inflammatory response, and this type of low-dose radiation had been used in the 20th century, in the prior century, to treat certain forms of drug-resistant pneumonia. You may also hear that there is a bit of controversy about the drug hydroquinone coupled with an antibacterial called azithromycin. Hydroquinone use is very dose dependent. Hydroquinone may have some effects directly against the virus, but it certainly can be effective against bacterial secondary opportunistic infection. But dosing is critical. Low doses may be effective, intermediate and higher doses can be toxic or fatal, which is why the simple recommendation for the use of hydroquinone is not prudent at this time. The reason for that is that patients who have COVID may have problems, may have dysfunctions of their respiratory system, renal system, and liver system that can rapidly lead to dose variations in hydroquinone, which could be fatal. Clearly, if we're looking at those things in terms of the time course, as I mentioned earlier, the peak will be probably end of April to mid-June, but there is also the possibility of an autumnal rebound. Things that will affect the rebound are as we have listed here. But I think the larger issue here is, what does this mean as we go forward for health promotions? We need to be prepared. We need to promote those practices that we now understand are very important for our individual and public health. Hand washing, understanding the need for, in some cases, distancing and early treatment of those individuals who are sick. But the other issue speaks to the fact that the more we're engaging a variety of different environments, the more we become susceptible to the increasing effects of climate change, for example, the higher the likelihood that we will indeed interact with animal species and animal environments that make us susceptible to, make available to us, particular diseases and disorders that were not necessarily viable to us in the past. The more we engage in a lot of the activities we had of social crowding, large-scale travel, the more we recognize that we may be susceptible to other forms of diseases like COVID-19 in the future. So what we suggest is a health promotions four-thrust approach. First thrust, increase awareness that these things are out there and in fact could be viable threats to public safety and public health. Quantify the threats. How much of a threat is this? How soon? What is the nature of the threat? What must be done to counter the threat? And ultimately, in the fourth thrust, prevent or delay what we call adversarial effectiveness. What are those natural adversaries of disease, disorder, of illness that we know will affect our health? And how can we better promote our health so as to mitigate their signs and symptoms when they occur, or most ideally, take a health promotional approach that is preventive? What we've called for is a whole of nation and multinational cooperation. Clearly, peoples and nations must work together ever more as we move into this new global shift of the 21st century, where we encounter each other's environments, we spread into a variety of environments, and our technology allows us to have interpersonal contact on a number of different levels. I apologize for the typography, for the typographical error in the slide. That word should be approach, not apparak, so it's approach. But clearly what becomes important for us to understand is that reaction, while critical, takes second place to awareness, prevention, and promotion. I hope I was able to provide you with some facts about COVID-19. I hope that the facts that I have provided for you give you some peace of mind and also give you information that will help you to engage health promotion on both your level and a community level. I thank you for your time, and if you need to get in touch with me, this is where you can reach me. Nico, over to you.
Thank you very much, Jim. This was brilliant, and I'm very glad that you took the time to speak to my students, and hopefully it was of use to the students. And I would like to, if your time allows, to take some of the questions raised by the students.
Yes, absolutely.
So, students, you are now, it's your time. You may actually start. I already allowed you to activate your microphone as well as your video. So in case you have any questions, go ahead, or probably you just want to say thank you, or in the name of all of us, a large and a huge thank you to Jim Giordano for giving this brilliant presentation. And now the floor is yours. I'm eager to learn what your questions are. Maybe the students take some more minutes, so let me take the opportunity to ask some questions that I'm interested in. What is your opinion at the moment? What is the country that is currently addressing the epidemiological crisis at its as a sort of best practice example?
Well, I can tell you it's not the United States. This much I think anyone in the United States will tell you. Again, I think that they've actually done a very good job in reactive control in China. So it's important to give credit where it is due. And of course, there is the suspicion of some early misinformation about the severity of the epidemiological spread in China, its epidemic proportions. That withholding, they have done a good job in the social controls necessary to then flatten the curve. But of course, this is a closed society, and it is something of an authoritarian society. So we can look to a society like that and certainly give them the credit, but then this, I think, has to be mitigated with an understanding of that approach might not be applicable, universally applicable in other societies. That said, we can look to a country like Singapore that has done a very good job. South Korea has done a very good job. And notably, Germany has done a very good job, utilizing different approaches. Singapore has employed their military to be able to augment public health. South Korea has not, but has certainly had a very strong governmental response. And Germany has taken less of a centralized response, using more of a decentralized response, where the various regions have then put into place health promotions and public health measures that have then allowed for adequate testing, physical and social distancing, and treatment.
Okay, interesting. And what are your expectations concerning not so well developed countries such as Africa or Southern America? I mean, how is that going to affect the crisis on a larger time scale?
Well, I think with the reduced travel that we're seeing at present, those countries are not necessarily seeing the first wave spike in their epidemiologic numbers. However, their vulnerability remains high because of the absence of intranational resources for health promotion and health care. And so the potential for this pandemic to have devastating effects in developing or undeveloped countries is very high.
Okay. And last question from my side, and then I would like to turn it over to the students. So students, get prepared. You know, you're very familiar with our health promotion program here in Coburg, and I wonder what are your expectations and what is your perspective on how could our health promotion students get engaged with helping with this crisis and how to deal with it?
No, I think the answer is twofold. I think there are two parts to that answer: immediate and long term. I think that immediately, health promotion students gaining an understanding of what the various health systems are, not only in Germany but worldwide, can then become more useful by seeking job opportunities in those health systems on a variety of levels. As we've seen from this COVID crisis, health promotion doesn't just involve health care, it also involves communication, policy, education. So I think understanding that becomes very important moving forward, and also understanding what they're learning in the program in health promotions now should be evident of being highly important to global health in the future.
Okay.
But I think the larger issue, Nico, is that a program in health promotions will be seen as increasingly important given the devastating effect that this pandemic has had. I think for far too long, we've taken public health, I'm not going to say for granted, but we've taken public health in stride as just a natural occurrence of developed countries. What we now understand is that those systems of health promotion, public health, and biological safety and security can always use an increased workforce, always require support, and will become ever more important in the future.
Okay, great. I couldn't agree more. So are you actually able to see the comments students are writing in the chat, or do you want me to read them loudly?
No, if you could read them, because I'm not able to share screen them.
So first of all, I start with an easy one. Professor Giordano, what do you think of the curfew policies in Sweden? Is it irresponsible to have none at all?
Curfew versus social distancing. I think that physical distancing policies are important. I think that curfew policies certainly can be important. And I think that where you don't see curfew policies in place, it becomes important to reflect whether those curfew policies reflect the epidemiological incidence and prevalence of the disease in that area. So it really isn't my place to say whether they're irresponsible. The question is, are they appropriately responsive? So if in fact the numbers in Sweden are indeed low, if the suspicion is that the epidemiological spread in Sweden will remain low because the incident cases are low, then social controls can be appropriately responsive. However, what is of real concern is that a number of people are not symptomatic, are not getting tested, and therefore may be carriers. So what we worry about in those instances where there is no physical and social distancing or curfew or quarantine is that there may then be a second or third peak internationally that then may reignite the global pandemic.
Okay, good. So you're also a neuroethicist as well as a medical expert in medical ethics. And one of the questions that came up, of course, is how do you assess President Trump's approach towards taking care of the exclusive rights of the vaccine that was being developed? I think he wrote in Thuringia, but I think he meant Tübingen, of the name of CureVac, if I'm not mistaken.
Tübingen, yeah, it was Tübingen. Being a neuroethicist does not allow me any expertise in political commentary.
Okay.
But what I will say is I will reinforce this slide. And the bottom of that slide is critical. Whole of nation, in other words, within every country that is feeling the impact of this pandemic and or future epidemics or whatever crisis they face is going to be important. Government working directly with research, working directly with the commercial sectors becomes critical to be able to mobilize the resources and services that a country needs. But this is a pandemic. It is global, and there are other global problems that we must face. So a purely nationalistic approach that excludes other nations, that in some way hobbles other nations, and in some way is problematic to international collaboration and cooperation is not the way forward. International cooperation is critical.
Very prudent answer. Thank you so much. Another question here about wearing masks. Someone asked that does this damage the immune system as a whole, since it does not longer come in contact with the modeling environment? So does it have a rebound effect, wearing masks?
No, I think that the idea of wearing masks is at this point temporary. It also depends on the type of mask. I mean, certainly the industrial grade, what we call N95, this is the N95 mask, that is the mask that is most advocated, is used in those situations where you're in direct contact with a pathogen. The idea of wearing masks right now is twofold. Number one, those individuals who may have an infection who do not know it, it's blocking the infection from spreading. And number two, it provides a simple but not complete barrier against aerosolized droplets then contacting the nose and mouth. So the idea of wearing masks, excuse me, is temporary, number one. But obviously, we're in contact with a whole range of environmental pathogens and antigens, and simply wearing a mask is not going to impair the immune system.
Okay. Well, no question at that point in time. So I will ask you another question. I mean, I remember you talking to my students about triage in the 7th semester health promotion ethics lecture. How do you assess the overall necessity to apply triage? And probably you want to explain shortly what that is to the student and what it implies and how it should be dealt with, because obviously what we are seeing at a global scale is lack of resources, be it ventilators, be it masks, be it gloves, whatever, in order to tackle and deal with that crisis, particularly for medical personnel.
Correct. Triage is used to allocate resources and services to those patients who require it most. So it is a system of evaluating particular patients for the relative viability and success of what certain treatments may offer them. That's a very fancy definition, and what it basically says is initial assessment, and then what do we do with these different patients? In other words, it determines extent and level and type of treatment based upon the patient's condition relative to the resources that are currently available at large. The more the situation becomes a crisis situation, the more triage becomes important, because you have a higher volume of patients, a greater number of patients that need to be seen in a particular amount of time. And if you then superimpose, if you then add to that a decrease in resources, goods, and services, those variables become interactively far more critical. Literally critical, where one must then be critical and criticize who gets what for what reasons. So what we're seeing now is that the importance of successful triage has really been put into stark relief as a consequence of decreased availability of resources necessary for the care of the severe and critically ill. Triage is vital.
Okay. Another question came up. How long should the greater public be locked down? And if there is no more social distancing, at some point, will the curve then increase again? And are we sort of losing our resources at the moment because we can't, at a later point in time, we will not have the resources in hand that will be necessary in order to tackle the crisis?
Yes, that's a very good question. So at this point, we're anticipating that the peak of the epidemiological and/or pandemic spread, at least among developed countries, is between the end of April and early June. There are a number of reasons for that. Obviously, physical distancing and individuals' hygienic practices practiced on a large scale flattens the proverbial curve. This virus does not seem to be temperature dependent. And the reason we say that is that clearly the virus became epidemic under conditions of extreme cold in China. And we also understand that it's spread to both temperate climates and those that are more severe with regard to heat has also been noticed. So it doesn't seem that just the temperature and humidity appears to be a meaningful factor in the spread or propagation of the virus at this time. However, one of the natural effects of coronaviruses is that you tend to see a decrease in the number of infections in the warmer months, in other words, the summertime.
Okay.
The reason for that is mostly because of distancing in summer. People are not in tight environments indoors, they're outdoors. The issue here may also be that the virus itself changes some of its characteristics. Let me briefly explain. What many viruses will do is they will increase their capability for infection, but become less potent or severe in the infection itself, so as to then advance the viral material more profoundly, more robustly. So what you'll see is that more infections, but less severe symptoms and signs with time. We anticipate that if just allowed to engage what's called the natural history of the virus, it will peak probably by June, taper off by summer, but we do anticipate that when people come back together in those closer environments without any physical distancing, there is the possibility for what we call an autumnal rebound, a spike again. So what becomes important, for example, is what our director of the National Institute of Infectious Disease, Anthony Fauci, has referred to as the new normal. Perhaps people will not be shaking hands in the future. Perhaps we will need to understand social distancing. But what is going to be important is not only increasing our hygienic practices, but there are other things that will mitigate a reoccurrence. Viability and availability of testing. Who's been infected and who is immune? Who is infected and who is a carrier? Who has not been infected and who is vulnerable? Treatments. If we're able to get a treatment available and rapidly on the market, such as one of the antivirals, then clearly we can reduce the signs and symptoms of those individuals who catch this virus in the future, and it will be less than severe. And ultimately, the development of a vaccine will be useful in its prevention.
Great. Here's another very interesting question from one of the 7th semester students who already enrolled in your health promotion ethics class. So in a sense, let me start with, I mean, this is my language. We have responded in a very Kantian way towards this crisis. And now we're talking about a more utilitaristic point in this whole affair. And the question is, what do you think, how long are our societies able to bear the curfew policies? Ethically seen, don't we also have to consider all the people losing their jobs, home existences, which is probably even more severe in America than in our social system, and all the severe psychological and psychosocial problem, as well as the domestic violence, which is on the rise, and how do you gauge that against each other?
Yeah, that's a very good question. So the idea of a purely Kantian deontological or duty-based approach that then has to interact with a more utilitarian or consequentialist approach, I think becomes important, but also, obviously, there's we call it an agentic approach. In other words, each and all of us can become an agent to limit the spread, if not prevent the spread of this disorder. So all three of those major ethical systems, the deontologic or duty-based ethics, consequentialist or consequence-based ethics, and virtue or agent-based ethics play a role. But your question is a larger one. It speaks to the idea of ethically, how do we approach the public health? And at the same time, how do we approach the public health as it concerns socioeconomic stability?
Plus add to this individual rights.
Oh, without a doubt. Without a doubt. I mean, so what you see is the balance of what is social and what is economic in terms of how individuals use their resources, not just money and financial stability, but the idea of social resource engagement. So how people have freedoms to be able to do what it is they want to do. So in a recent op-ed to CNN, my colleague, Dr. Daniel Gerstein, and I described this as a two-horned dilemma. One horn is the very sharp horn of maintaining the public health, treating people, preventing the spread. And to do this, we require physical distancing, curfews, and quarantines. But in doing that, we're then impacting socioeconomic stability. People are losing jobs. The economy is taking a hit and not doing well, if not crashing. It's causing global economic instabilities. And then psychologically, this is now producing problems for individuals who are feeling financial difficulty, if not facing financial ruin. So what we approach is that both of these need to be addressed together.
Mhm.
The primary interest, of course, is in public health, which is why it is so important to initiate broad-scale testing to determine who has been infected and who may be immune, who is currently infected and may be actually spreading virus,
Mhm.
and who is most vulnerable and must be protected.
Mhm.
By doing this testing, without any form of treatment or vaccine, we may be useful or may be helpful in determining who can return back to the workforce and who
Mhm.
might not be able to return to the workforce.
Mhm.
This might help to restabilize the economy.
Mhm.
Once we also determine through testing who is infected, who is immune, and who is vulnerable, we can
Mhm.
also then perhaps prioritize who gets certain treatments so as to make those individuals who are infected well, to
Mhm.
take those individuals who've been infected and make them immune,
Mhm.
to keep individuals who are immune,
Mhm.
and to make the vulnerable immune via a vaccine.
Mhm.
So doing these two things together, we believe, will help to address the primacy of individual and public health, and at the same time address the immediacy, urgency, and
Mhm.
importance of socioeconomic restabilization.
Okay, interesting. So let me add, our countries have different societal models. So we have a more or less developed social welfare system, whereas in the States you have a more capitalistic system. So at the end of the day, how will these different types of models deal with the crisis? And at the end of the day, will we see a semi-socialized America, or how is that going to develop? What is your assessment?
Uh, I'm going to give you my opinion, not my assessment, once again, because I don't feel that I don't possess the expertise um, or the credentials as a political scientist to be able to make any real empirical assessment about America's political situation and our social responsivity to politics. That said, this is my opinion only. It is my opinion that many Americans, have issues or problems with the concept of broad scale socialization, a broad scale sort of socialized system. Um, Many people equate that form of socialism with a form of communism. And of course, that really has issues for the what I would call greater American psyche, or at least it did. Certainly, we see that as being one of the critical points of former candidate Bernie Sanders' presidential campaign.
I see. Mhm.
But I think that the issue here is a larger issue. It's not necessarily a question of pure socialized healthcare, but rather, do we have, or does any nation have, a system of healthcare that adequately addresses the needs, the values, and the functions of its population? And I
Mhm.
think that arguably, a single party payer system or a single party provision system that then enables all individuals who are taxpayers to be able to have a certain access to broad-based medical care can be very effective. It's just a question of how that plays in, and once again, what that means with regard to the needs and values of the populations who are being served. As you know, I personally am an advocate of a more socialized form of healthcare provision and distribution, because my feeling is that what this would then do is it would utilize the general tax base in such a way as to provide relative healthcare stability for the population. But this is not without political debate. This is not without
Mhm.
difference of opinion. And I think clearly it's, as we like to say, it's beyond my pay grade. The political and sociological ramifications of those types of larger questions of a socialized versus quasi-socialized versus non-socialized governmental and political structure are beyond my expertise.
Okay, thank you. So we're coming to the end of this lecture, and students, if you want to ask two more questions, that's fine. One is already here. How useful are large-scale disinfections at subways, parks, public transportation, etc.? Is it more panic-inducing, or is it a good and effective measure of hygiene that is being provided here?
I think it can be a very effective measure of at least control, if not absolute hygienic prevention. We know something like the COVID-19 virus has particular durability on plastic surfaces and on metal surfaces. And so institutional disinfection of those surfaces on a routine basis will certainly be contributing to limiting the spread and the infectiousness of the virus. I think that there is the risk of two things. I think there is the risk of inducing certain social panic, but I think there's also the risk of inducing a certain social laissez-faire, a sort of devil-may-care attitude, if you will. The idea of, well, this is disinfected, so therefore I, as an individual, don't have to take necessary precautions, don't have to worry about disinfecting it myself, or can be somewhat more cavalier in my personal protection methods and applications. So what I think becomes important is that these ideas of institutional disinfection of trains, buses, shopping centers, shopping carts, etc., is certainly important to help to limit the spread, but I think that they should not be seen as a substitute for individuals' personal health promotion and community health promotions as well.
Okay, very good. So last question, this is a heavy one. Oh boy, it addresses the role of the media. And one student is asking, some people are still downplaying the crisis by comparing the numbers of infections and or numbers of fatalities to those of the regular flu that we have seen in recent years. Is that a reasonable comparison? And I would add, how is the media dealing with that? Is it a good way to put up soccer-like league tables counting fatalities and numbers of infected and recuperated persons, or what is your opinion on that?
No, I think there's a tremendous amount of misinformation that is out there, as we've seen from this slide. Things that range from this being a biological weapon to things that say that this is no worse than the flu or the common cold. Clearly, this is a viral pandemic. We've seen large-scale epidemics in the past: SARS, MERS, H1N1, Ebola. Historically, we know there have been a variety of epidemics, and we can look back to 1918 in the influenza pandemic. But I think comparing 1918 to the present is difficult because we're 100 years in the future and societies are different, mechanisms for communication are different, and certainly the technological capabilities are different. But I think the question is a good one. One of the things that I feel is very problematic is misinformation across all levels. Misinformation locally, misinformation nationally, misinformation on the small scale, and misinformation in terms of the large scale, in terms of what government is telling the people. So I think the media plays an important role in that. Clearly, what we know about media is very often there is some tendency towards sensationalization, particularly early on. And again, this is not uniform, but very often we know that bad news can sell. We also know that controversy can sell. And what becomes important in situations like this is to have a reliable resource, at least within some aspect of the media, that is going to be a go-to mechanism for those individuals who seek the information not only that they need, but that will be very important, that is needed on a local, national, and international scale. So I think with a situation like this, it becomes, it's foolish to compare this directly to influenza, particularly seasonal influenza. I think in some ways, it's equally problematic to compare this to the influenza epidemic or pandemic of 1918, because I think this does represent a novel situation in its pandemic spread and its relative impact. This is serious. This is serious for all of the reasons we just spoke about. This is not the simple flu. This is not a simple cold, at least not yet. And what I mean by that is, what we need to now do is develop better mechanisms of detection and testing, effective treatment, and a vaccine. Once we develop effective treatment to reduce the signs and symptom severity in individuals who can catch COVID, which will likely become seasonal in the future, and or develop a vaccine against this COVID strain and perhaps other coronavirus strains, at that point, then comparison to seasonal flu might be more relevant. But I think it was a mistake to compare this to flu. I think early on we didn't have the necessary information to be able to understand the gravity of this condition and its impact on both national and international levels. And I think that some of that early misinformation led to inaction in some cases or failure of response in others that has now resulted in the situation we see globally.
Okay. Thank you so much, Jim. I mean, we're coming to the end of our 90-minute window. So do you want to say a couple of personal or specific words to the students? Some words of advice, strengthening the souls or whatever?
Well, I don't know if I'm strengthening their souls or not, but I think that what this certainly brings into relief is that a field like health promotions is critical. More and more how we define health on a personal level, on a public level, on a national level, and on an international level will require the education and training of individuals, not only from the sciences, but also from the humanities, not only from the life sciences, but also from the social sciences, not only in terms of individuals who will be dealing with epidemiology, but with individuals who will be dealing with education. So I think what this brings, again, into stark relief is the importance of health promotion, not only as an educational field, but as a discipline and practice as we move forward in this ever more globalized environment of the 21st century.
Okay. Thank you so much I know that you're very, very busy and probably you have to run up, down the hill and take your responsibilities. I very much appreciate in the name of my students that you took the time to address their questions, gave us some very important updates and insights, and maybe at a later point in time, sometime after Easter, we can come up with an update if you're available for that.
I think that would be wonderful, and I think it's important because, as I said earlier, this is a rapidly changing situation where our understanding of the disorder is developing, and I think our understanding to developing approaches to be able to mitigate or prevent disorder are equally developing. So as a consequence, an update would be an important thing to do, and even for those students who are on this call, perhaps a call a couple of weeks in the future might be useful to then keep us current.
All right. Thank you so much. All the best for you. And of course, happy Easter. Stay healthy. The same to my students. Thank you for joining in. And frohe Ostern wünsche ich Ihnen. Alles Gute, bleiben Sie gesund und bis bald. Dankeschön.
Natürlich, dasselbe. Wiedersehen.
Wiedersehen. Danke.